Your STEMI patient just came up from cath lab, so here are 5 tips to keep these patients stable. So tip number 1 is going to be to monitor for reocclusion or stent failure. Just because these patients got stented doesn't mean that they are out of danger necessarily, because stent failure or reocclusion can happen very rapidly. So what we are going to look for is ST segment elevation, new chest pain, or instability. And if any of these things happen, you want to call cardiology and get a stat EKG. For tip number 2, we want to make sure that we are assessing and managing any complications that are happening at the access point. So this could be either radial or femoral. And for these sites, we want to check for radial, we want to check for pulses and for any hematomas that are growing there. And for femoral, we want to look for things such as a growing hematoma or signs of retroperitoneal bleeding. This can be a very silent but deadly complication from femoral access. So we want to look for hypotension, increasing heart rates, increasing flank pain, and dropping H&H that could be giving us clues that we are having a retroperitoneal bleed that needs to be fixed as soon as possible. Tip number 3 is going to be to optimize hemodynamics and monitor for cardiogenic shock. Just because we got a stent placed doesn't mean that we can't still have infarcted tissue or stunned myocardium. So we're going to be monitoring for urine output decreases, cool extremities, and rising lactate levels. So we can also anticipate using things such as pressors or inopressors like milrinone and dobutamine if we do experience cardiogenic shock. For tip number 4, we are going to understand and recognize reperfusion dysrhythmias. So this could be an accelerated idioventricular rhythm or short runs of VTAC even, but these could be good signs that we actually have good reperfusion of that area of the heart. So because of different things that happen whenever we reopen these coronary arteries, it causes instability and irritation of this myocardium leading to these dysrhythmias. So these could be a good thing, and they usually do not lead to deterioration, but if a patient does become unstable, then we do need to run ACLS protocols. And finally, for tip number 5, we want to make sure that we are preventing secondary complications. We don't want to just stop at the heart. Our post-STEMI patients are actually prone to strokes, so we want to make sure that we are doing neuroassessments, and they are also prone to contrast-induced nephropathy, so we want to make sure that we are monitoring creatinine and making sure that our patients stay hydrated. If you want more information on identifying STEMIs or STEMI locations or any other critical care topics, go ahead and check out the resources that are linked in my bio.